We're covering part 2 of the section about drugs that affect the heart, blood vessels, and blood volume. First, we're going to review the drugs used for heart failure. Well, heart failure is a progressive and often fatal disorder, and you will see ventricular dysfunction with reduced cardiac output, insufficient tissue perfusion, and will have signs of fluid or volume overload retention. So you'll see peripheral edema, shortness of breath. Many times a myocardial infarction has occurred and it creates this cascade leading towards heart failure. And you can see here a list of other heart disorders that are connected to heart failure. It's important to understand this disorder because over 6 million Americans are affected, and mainly it's our older patients. Up to 8% of our patients are over the age of 65, and up to 12% of these patients are older than 80%. So there are direct and indirect healthcare costs associated with heart failure at an estimated cost of $30 billion every year. This disease has two major forms. We have heart failure with left ventricular systolic dysfunction, and we now refer to this mainly as heart failure with reduced ejection fraction. We also have heart failure with diastolic, or we call it diastolic heart failure, and this is when we have preserved left ventricular ejection fraction. But in the next couple slides, we really are focusing on a heart failure with left ventricular systolic dysfunction. So when there is an insult to the heart, cardiac remodeling will take place, and in that first phase of heart failure, this is when the heart will start to undergo this remodeling process, and the ventricles will begin to dilate, become hypertrophied, and more spherical. These alterations in the cardiac wall will increase the stress and reduce the left ventricular ejection fraction. So why does remodeling occur in the first place? Some type of cardiac injury had to happen, and again, typically it is started by a myocardial infarction. The remodeling process is driven primarily by our neurohormonal system, which includes the sympathetic nervous system, or SNS. Our RAS is also part of the equation as well, remembering that that is the renin, angiotensin, aldosterone system. So the neurohormonal factors not only promote cardiac remodeling, but also cardiac fibrosis and myocyte death. And the net result of all these pathological changes is the progressive decline in the overall cardiac output. Cardiac remodeling will precede the development of these symptoms, and they will continue after they appear, and as a result, the performance of the heart, or the cardiac performance, will continue to decline. The cardiac dilation is characteristic of heart failure. The dilation results from a combination of increased venous pressure and reduced contractile force. And because we have less force, it's going to lower the amount of blood that can be ejected during systole. That end systolic volume is going to rise, and the increase in venous pressure will further increase the diastolic filling, causing the heart to expand even further. Now, if you remember Starling's rule or law or mechanism, the increase in heart size that occurs in heart failure will help improve cardiac output. As your heart fails, the volume expands, contractile force will increase, causing this corresponding increase in your stroke volume. But the maximal contractile force that can be developed when your heart is already failing is considerably lower than the healthy heart and the maximal force that your healthy heart can provide. And you can see how this curve reflects this limitation that you see in heart failure. Now, if cardiac dilation is still insufficient to maintain cardiac output, you have to also remember that there are other factors that come into play. We also will see increased sympathetic tone. Heart failure causes arterial pressure to fall. So your baroreceptor reflex, which increases your sympathetic output to the heart, the veins, and the arterioles, while at the same time, parasympathetic effects will also reduce in the heart. The overall consequence is going to be an increased sympathetic tone. You're going to see in your patient an increased heart rate, and this acceleration of heart rate will increase the overall cardiac output. Initially, it's going to help improve tissue perfusion. However, if your heart rate increases too high, there's not going to be sufficient time for your ventricular filling to complete. Therefore, your cardiac output is going to be reduced. You're also going to have increased contractility. During this contractility, or this increase of contractility, there is the obvious benefit of also increasing cardiac output. The only thing that is wrong with this scenario is that if there's an increase in cardiac output and cardiac contractility, there's also an increase in cardiac oxygen demand. We also will notice an increased venous tone, and this elevation of venous tone will increase your venous pressure. The problem with this increase in venous pressure is that we'll have an increase in ventricular filling. And because of Starling's law, we know that increased filling increases your stroke volume as well. But when venous pressure is so excessive, that blood is going to back up more than it can be pushed out because the ventricles are failing. We're going to have a very aggravating pulmonary and peripheral edema as a result. So excessive filling pressure can dilate the heart so much that your stroke volume is going to decline. And lastly, you're also going to notice, in addition to increased venous tone, is increased arteriolar tone. This elevation in arteriolar tone will therefore increase arterial pressure. Why is this important? Well, when you increase your arterial pressure, you're increasing perfusion to the vital organs. Doesn't this sound like a great thing? Well, unfortunately, your increased arterial pressure also means that your heart has to pump against a greater resistance. And because your cardiac reserve is so minimal when you have heart failure, your heart isn't going to be able to meet this demand, and your cardiac output actually will start to fall. Now, we will see water retention and increased blood volume. And this retention results from two different mechanisms. First, this reduced cardiac output will cause a reduction in your renal blood flow. This is going to decrease your GFR, or your glomerular filtration rate. Well, what is going to happen to your urine if your GFR is decreased? Your production of urine is also going to be decreased, leading to retained water. Now, while this is going on, you also note that heart failure is going to activate your RAS system. It's going to understand that there's reduced blood pressure and reduced renal blood flow. Renin will become activated, setting off the rest of the system, promoting water retention by increasing the circulation of aldosterone and angiotensin II. Aldosterone is going to act directly on your kidneys to promote further retention of sodium and water, and angiotensin II is going to cause constriction of the renal blood vessels. All of this is going to decrease your renal blood flow, decrease your urine production. Additionally, angiotensin II will also cause constriction of your systemic arterioles and your systemic veins. Thereby, you're also going to have an increase in venous and arterial pressure as well. Now, our body can try to adapt to some of these things. Increased blood volume can be beneficial, but it also can be harmful. When your increased blood volume triggers the venous pressure to also increase, you're also going to have increased venous return. As a result, that ventricular filling and stroke volume will increase. The net result is that you'll have an increase in cardiac output to improve your tissue perfusion. But just like we've talked about earlier, if venous pressure is too high, then we have edema of the lungs, and your peripheral vascular system will become edematous as well. If the increase in cardiac output is insufficient to maintain your kidney function, renal retention of water is going to progress, and there's not going to be anything to help offset it. The resultant accumulation of fluid is going to cause severe cardiac, pulmonary, and peripheral edema, leading ultimately to death. Lastly, understanding the role of natriuretic peptides will be important as well. Now, when your atria is stretching and your ventricles are dilating, in response, the heart is going to release two natriuretic peptides, your ANP and your BNP, your arterial natriuretic peptide and your brain natriuretic peptide. These hormones are going to promote dilation of the arterioles and the veins and a loss of sodium water through the kidneys. Now, there tends to be a counterbalance of vasoconstriction that's caused by your SNS and your angiotensin II, as well as a retention of sodium and water that was triggered by the RAS. But when your heart failure progresses, the effects of your natriuretic peptides become so overwhelmed by the effects of your SNS and your RAS. The level of BNP that's circulating, that brain natriuretic peptide, is an important index for your cardiac status. And so watching BNP of your heart failure patient is going to help predict long-term survival. When you have high levels of BNP, this is going to indicate poor cardiac health, predicts a lower chance of survival. This low level of BNP will indicate better cardiac health and predict a higher chance of survival, conversely. The use of diuretics are very common with heart failure patients, and it's the first-line drug for any patient that has signs of fluid overload or volume overload. Even if they have a history of volume overload, a provider might work prophylactically to reduce further signs and symptoms. And if we can reduce blood volume, then we can decrease venous pressure. We're going to decrease arterial pressure, pulmonary edema, peripheral edema, and cardiac dilation. However, you don't want to excessively diurese your patient. It needs to be avoided because the result could lead to a blood volume that drops too low, decreasing your cardiac output, and overall your blood pressure is going to fall very quickly. this is going to compromise the tissue perfusion of your already compromised patient. And for the most part, the benefits of using a diuretic is really just limited to reducing the symptoms from volume overload. It's not going to prolong the survival of your patient. However, drugs that inhibit the renin-angiotensin-aldosterone system, or the RAS, actually do have the ability to prolong life. The RAS system, or the RAS, plays an important role in both cardiac remodeling and hemodynamic changes that often occur in response to reduced cardiac output. So if we can reduce or inhibit RAS, we're going to see the benefits. There are 4 drugs that we're going to talk about: ACE inhibitors, ARBs, aldosterone antagonists, which we've discussed already. The one group that may be less familiar is the direct renin inhibitors, or the DRIs, and we will discuss those as well. Well, first we'll talk about the ACE inhibitors. These are essential heart failure therapies, and why providers use them is that it improves functional status and it prolongs life. In addition to using an ACE, which you could use an ACE inhibitor by itself, we usually will combine an ACE inhibitor with a beta blocker and a diuretic. ACE inhibitors will block the production of angiotensin II, which will then further decrease aldosterone from being released and suppress the degradation of kinins. The net result is going to be the improvement of your hemodynamic status, and it also is very favorable to the alteration of cardiac remodeling. Let's look into the hemodynamic benefits a little bit closer. ACE inhibitors are going to help by arterial dilation. This is going to improve the regional blood flow in the kidneys, other tissues. If we can reduce afterload, it's going to increase your stroke volume and your cardiac output. This is also going to increase the renal blood flow, which will excrete more sodium and water. We also see the benefit of venous dilation. It reduces venous pressure, and thereby we're going to have improvement with pulmonary congestion, peripheral edema, preload, and cardiac dilation. We will also see with an ACE inhibitor the suppression of aldosterone release, and this is again going to enhance the secretion of sodium water, but it can also cause a retention of potassium, so just remember that. There are some adverse effects that we have to think about, and with heart failure, our principal adverse effect that we're looking for is hypotension, and this is secondary to the arterial dilation. We will also see hyperkalemia secondary to that decreased aldosterone release. And then the common symptoms that we're more familiar with ACE inhibitors, or adverse effects, are intractable cough and angioedema. Now, if you give ACE inhibitors to a patient with bilateral renal artery stenosis, however, this is going to cause renal failure. But because of the ability to elevate potassium levels, ACE inhibitors should be used with very, very much caution in patients that are taking potassium supplements already, or if they're on a potassium-sparing diuretic like spironolactone. Now, the adequate doses is still debated in the literature, but the best way to approach an ACE inhibitor for a patient is to go low and slow. And you'll choose a low dose and slowly titrate until you find a treatment dosage that the patient can tolerate. Now, angiotensin II receptor blockers are very similar to ACE inhibitors, but they're not identical. We'll have the same benefit of hemodynamic effects, and we'll see a reduce in heart failure symptoms, increased exercise tolerance, decreased hospitalization, increased or enhancement of quality of life, but most importantly, it will reduce mortality. But because ARBs don't increase your kinin levels, you're not going to see the effect on cardiac remodeling. But because of that, our patients that can't tolerate an ACE inhibitor usually can tolerate an ARB because ARBs don't increase your bradykinin levels. Therefore, you're not going to see this cough. Aldosterone antagonists, like spironolactone, can reduce the symptoms overall of heart failure, decrease the hospitalization, the length of stay, and prolong life. The current guidelines for heart failure actually recommend adding aldosterone antagonists to your standard heart failure therapy, but only in patients that have persistent symptoms with ACE inhibitors and a beta blocker. So what I'm saying is, if you're already on the standard care of ACE inhibitors, beta blockers, and it's still not working, you can add aldosterone antagonists. These aldosterone antagonists are going to work by blocking aldosterone receptors in the heart and the blood vessels. Now, researchers believed previously that all aldosterone did was promoted renal retention of sodium and water in exchange for potassium. But now we know that aldosterone has additional and more harmful effects. It will promote myocardial remodeling, improving the pumping. It promotes myocardial fibrosis, which increases the risk for dysrhythmias. It activates the SNS and suppresses norepinephrine uptake in the heart. This can promote dysrhythmias and ischemia. Using a aldosterone antagonist can also promote vascular fibrosis, which will decrease arterial compliance, and it promotes baroreceptor dysfunction. With a patient with heart failure, activation of the RAS causes aldosterone to rise. These levels are going to increase. And in some of those patients, these aldosterone levels are 20 times the normal levels. And as they get higher and higher, you're going to have an increase, obviously, of harmful effects. The prognosis of heart failure is going to become progressively worse as well. The medications that reduce the effects of aldosterone by either decreasing aldosterone production or blocking the receptors for aldosterone, ACEs, ARBs, and DRIs are going to be these drugs. They're going to decrease aldosterone production. Spironolactone will block aldosterone receptors. Now, although our ACE inhibitors and our ARBs reduce aldosterone, they don't block it entirely. And they're only going to be able to suppress it for a short time. And that's why ACE and ARBs aren't used alone. When an aldosterone antagonist is added to a regimen, any residual effects are going to be eliminated. So the symptoms of heart failure are going to be improved, and you can improve and sustain life. But just like the ACEs, aldosterone antagonists have a major adverse effect. Aldosterone antagonists will cause hyperkalemia. And this underlying cause is the renal retention of potassium. If you already have a patient with renal impairment, by using an ACE inhibitor or an ARB, it's going to increase. So, how do we minimize the risk? Potassium levels and renal function they have to be measured first at baseline, and then you are going to measure them serially after or periodically. If your patient is on a potassium supplement, you have to discontinue the potassium. Another adverse effect that is primarily just spironolactone and not the other types of aldosterone antagonists. I'm trying to think of the drug name at the moment here. well, anyways, they are going to cause gynecomastia or painful breast enlargement in about 10% of males. Okay, so taking it back to spironolactone, that's what's going to cause the gynecomastia. Oh, the other drug, eplerenone, that drug is also within the same class, aldosterone antagonists. And if you experience a patient that complains of gynecomastia on spironolactone, you can use eplerenone. Okay, finally, we're going to get to the direct renin inhibitors, and they can shut down the entire RAS. So, in theory, their benefits in heart failure should be equal to ACE inhibitors and ARBs. There is a drug called elascarin. It has the trade name Tecturna, which is already available for heart failure. But in recent trials, this drug, Tecturna, didn't really improve the hospitalization of patients with heart failure. And so there are still more studies out there that are being conducted right now. And because of this, direct renin inhibitors aren't usually a first-line treatment. We do have approval for Tecturna currently for hypertension only, but not yet completely approved for heart failure. Now, the role of a beta blocker in terms of treating a patient with heart failure continues to evolve. Previously, heart failure was considered an absolute contraindication for using a beta blocker. Because think about, if you're causing the blockade of the beta 1 adrenergic receptors, you're going to reduce contractility. And of course, if we reduce contractility in a patient with heart failure, you could cause detrimental effects because you're already dealing with a heart that's compromised. But more recently, we understand that if we carefully control the dosage of the beta blocker, it will improve the patient's overall status. There have been controlled clinical trials that show 3 different types of beta blockers being used effectively on patients with heart failure. Carvedilol, bisoprolol, and we have the sustained release of metoprolol. When added to a conventional heart failure treatment plan, using an appropriate dose of beta blocker will improve left ventricular ejection fraction. It will increase exercise tolerance and slow down the progression of heart failure. Patients that take beta blocker in addition to the rest of their heart failure regimen will reduce the need for hospitalization, but most importantly, it's going to help prolong the survival and the prognosis of the patient. So because of all these benefits, beta blockers are now recommended as first-line therapies for our patients with heart failure. And they can be used in patients with severe disease as long as they are hemodynamically stable. Because excessive beta blockade reduces contractility, these doses have to be very low initially, and then you can gradually increase. You're not going to see the full benefit until about 1 to 3 months after prescribing a beta blocker for heart failure. So just like the other drugs, you have to think about the adverse effects. And the principal adverse effect for a beta blocker is fluid retention and then the worsening of the heart failure. You can see fatigue, hypotension, and of course, bradycardia or heart block because you're taking a beta blocker. We'll talk about digoxin. This actually belongs to a class of drugs that we call cardiac glycosides. And they're best known or used for their positive inotropic action, meaning that they increase contractility. By increasing contractile force, providing DIG can furthermore increase cardiac output. Additionally, if you alter the electrical activity of the heart itself, we can favorably affect that neurohormonal system. Yet, although DIG can reduce symptoms of heart failure, it's not one of the drugs that are really going to prolong the life of the patient. Previously, digoxin was used as a first-line treatment in heart failure, but now we use it only as a second-line treatment. Okay, so we're going to sum it up. Heart failure is treated with 3 types of drugs: diuretics, drugs that inhibit the RAS, and beta blockers. The other agents are used, but they're not first-line treatments. Now we're going to talk about antidysrhythmic drugs. First, understanding what dysrhythmia is. It's an abnormality in the rhythm of the heartbeat, and in its mildest forms, you're only going to see a modest effect on cardiac output. But when you have severe dysrhythmias, you can disable the heart from actually pumping enough blood or pumping any blood at all. Because of dysrhythmia's ability to compromise your cardiac function, it's associated with a high degree of morbidity and mortality. There's also 2 basic functions or types, of dysrhythmias. There's tachydysrhythmias and bradydysrhythmias. Now, we're only going to be talking about tachydysrhythmias. This is by far the largest group of dysrhythmias and the ones that will respond best to the drugs we're going to talk about. If you have a bradydysrhythmia, there are few treatments, but typically you're going to have to introduce electronic pacing or a pacemaker. When drugs are indicated, you use atropine as the first-line agent for bradydysrhythmias. But again, we're going to be talking more about the tachydysrhythmias. Now, we have to really understand the drugs that are used to treat dysrhythmias can also cause dysrhythmias. And therefore, if we're giving a drug that can create new dysrhythmias or worsening dysrhythmias, we have to be really careful and really understand these drugs. Antidysrhythmic drugs should only be used when the benefits of treating the patient clearly outweighs the risk of not treating the patient with the dysrhythmia. And for 2 reasons, the use of antidysrhythmic drugs or medications are actually declining. And I want you to know these 2 reasons. The first one is that research is showing that some of these agents are actually increasing the risk of death. And secondly, non-pharmacological therapies like implantable devices like implantable defibrillators or radiofrequency ablation have replaced the drugs and have become the preferred treatment for many types of dysrhythmias. Remembering that dysrhythmia also can be used interchangeably with arrhythmias. Because the term arrhythmia denotes the absence of cardiac rhythm, so arrhythmia. Dysrhythmia denotes an abnormal rhythm. So we are going to use dysrhythmia, which is a more appropriate term for what we're going to talk about and discuss. Let's first think about the electrical properties of the heart. dysrhythmias are going to result because there's an alteration of that electrical impulse that is first stemming from usually the SA node. And anti-dysrhythmic drugs are going to help to control that rhythm by correcting or compensating for these types of alterations. So we have to understand where the dysrhythmia is generating or generated from to understand the treatment. You need to go back and review the pathways and the timing of impulse conduction, the cardiac action potentials, and just the basic elements of ECG. First, when we think about the heart being a pump and needing to pump effectively, the atria and the ventricles have to coordinate in this contraction. And this coordination is achieved with very precise timing and very precise routing of this impulse conduction. And in a healthy heart, it's going to originate from the sinoatrial node or the SA node. It's going to spread rapidly through the atria. It's going to pass slowly through the AV node or the atrioventricular node. And then we're going to move very quickly again through the ventricles by the way of His or the Purkinje system, Purkinje fibers. Now, under normal circumstances, this SA node is going to serve as the pacemaker for the heart. And this pacemaking activity is going to result from spontaneous phases. Because the cells of the sinus node usually discharge faster than the other cells that display this automaticity, your SA node normally dominates all the other potential pacemakers. And after the SA node discharges, this impulse is going to spread rapidly through the atria along the internodal pathways, and this conduction allows the atria to contract in unison. The AV node also has a job. The impulses originating in the atria have to travel through this AV node to reach the ventricles. And in a healthy heart, the impulses that arrive at the AV node are delayed before going to excite the ventricles. And this is why it's a little bit more slower. This delay is going to provide time for blood to fill the ventricles before kicking off ventricular contraction. Now, the Purkinje fiber system consists of specialized conducting tissue, and the function of these fibers is to really conduct electrical excitation in a very rapid manner to every aspect of the ventricles. When you have stimulation of the His-Purkinje system, you're going to note that it's because the AV node has put off the impulses, so it's leaving the impulses from that node. These impulses are conducted rapidly down the bundle of His. They enter to the right and the left bundle branches, and they're going to distribute to the many fine branches of Purkinje fibers. Now, because this impulse is going to happen so quickly, all the regions of the ventricles are going to be stimulated almost at the same time. And this should produce a synchronized ventricular contraction with, hopefully, a good forceful ejection of blood. Okay, so hopefully you took time to review the conductivity of the heart, action potentials, and your EKG. Because now we're going to look at the classification of the antidysrhythmic drugs, and you have to be able to understand what the mechanisms of action are and what the desired effect is on the heart. So we have this classification, and we use the Vaughan Williams scheme. The antidysrhythmic drugs will fall into 5 different groups. This is important for you to understand and distinguish the 5 different groups. There are 4 major classes of antidysrhythmic drugs. We have class 1, 2, 3, and 4. This 5th group will include adenosine and digoxin. knowing where the drug lies in classes 1 through 4 is going to be determined by the effects on ion movements during a slow and a fast action potential. So, class 1 are the sodium channel blockers. They are going to block cardiac sodium channels, and when this happens, these drugs will slow impulse conductions in the atria, the ventricles, and in the His-Purkinje system. Class 1 constitutes the largest group of the antidysrhythmic drugs that we have. And examples of that would be like quinidine, Procan, and we have something you might be familiar with is Norpace, which is disopyramide. And our class 2 beta blockers, we're going to have beta adrenergic blocking agents. These drugs are going to reduce calcium entry during both the fast and the slow potentials, and it will depress the phase 4 depolarization in the slow potentials only. Now, beta blockers have 3 prominent effects on the heart. In terms of the SA node, it's going to reduce the automaticity. In the AV node, it will slow conduction velocity. In the atria and ventricles, it's going to reduce contractility. So, the cardiac effects of beta blockers are pretty similar to calcium channel blockers. In class 3, we have the potassium channel blockers. These drugs are going to delay repolarization. Class 3 drugs block potassium channels, delaying repolarization of the fast potentials. If we can delay repolarization, the drugs will prolong both the action potential duration. Class 4 drugs are the calcium channel blockers. We only have the 2 calcium channel blockers used as antidysrhythmics, and this is very important. We'll use verapamil and diltiazem. Verapamil and diltiazem are the only 2 calcium channel blockers that we use as antidysrhythmics. Calcium channel blockade has the same effect on calcium or cardiac action potentials as the beta blockers and the beta blockade. So these 2 calcium channel blockers, verapamil and diltiazem, have nearly identical effects on cardiac function because they're going to reduce the automaticity in the SA node, delay the conduction through the AV node, and reduce myocardial contractility. So the same things that we saw with the beta blockade. However, namely, we will see antidysrhythmic benefits deriving from the suppression of the AV nodal conduction. Now, there are other antidysrhythmic drugs like adenosine and digoxin, and they don't really fit in the other 4 classes, but both of these drugs will suppress dysrhythmias because they will decrease the conduction through the AV node and reduce the automaticity in the SA node. Very similar to that of calcium channel blockers and beta blockers. However, they don't work directly on the atria and the ventricles. Prophylaxis of atherosclerotic cardiovascular disease. We're going to be learning about drugs that help normalize your cholesterol and your triglyceride levels. If you have a patient with high cholesterol, using pharmacological treatment is not the first line treatment. It's always going to be lifestyle changes. This is going to help reduce LDL cholesterol. However, if lifestyle changes by themselves are not working to reduce your LDL cholesterol to an acceptable level, then we have to use it in combination with a medication. But what is going to inform us is the combination of the elevated LDL level and the patient's ASCVD risk category. This is going to be what justifies the use of drugs. When we do decide to use a drug, we need to know that it's essential not only to provide drug therapy, but our patient needs to understand that they will continue lifestyle modification, because the benefits of using diet and drugs is an additive one. The drugs alone aren't going to be able to bring the LDL levels to the goal that you're striving for. We also have to teach our patients that once you start a drug for cholesterol, it's a lifetime commitment. Once you stop using the drug, your LDL levels are going to return to those pre-treatment values. So helping them to understand this early might even be more motivation for them to work really hard on their lifestyle modifications. So what is the first line treatment though if you do have to use a drug? The most effective agents are going to be our 3-hydroxy-3-methylglutarol coenzyme A reductase inhibitors. Remembering that the critical step in hepatic cholesterol synthesis is catalyzed by this enzyme. So what are the HMG coenzyme A reductase inhibitors? Those are the class of statins, and we're going to use Lipitor or atorvastatin as the prototype. There are some newer classes of immunologics called monoclonal antibodies, and they can also treat high cholesterol. We also use, but less often, bile acid sequestrants, and we can use nicotinic acid. It's usually initiated by first using a single drug regimen, but more often than not, we start with the statin. If the statin's ineffective, then we'll move to a bile acid sequestrant, and then that can also be added to the regimen. And remembering, it's in addition to lifestyle modifications. In addition to lowering your LDL cholesterol, you want to try to target an increase of the HDL cholesterol. And the most effective way to do this is using a fibrate. Virtually all the drugs that we use to lower LDL cholesterol have this added benefit of increasing your HDL cholesterol, at least to some degree. And the rise of HDL can be considered the beneficial side effect of using a statin. We have to remember that high cholesterol is just one component of an overarching metabolic syndrome. Remembering that metabolic syndrome is a group of metabolic abnormalities that are associated with increasing your ASCVD risk as well as type 2 diabetes. So high blood pressure, high glucose, high triglycerides, high apolipoprotein B, low HDL, small LDL particles, being in a prothrombotic state and a pro-inflammatory state are all going to increase your ASCVD and make up metabolic syndrome. Now, there was a joint statement that came out with many different task force and associations like the International Diabetes Federation, the World Heart Federation, American Heart Association, and others that have come out and said, these are our levels. Okay, these are our levels that we're going to use as target treatment levels. High triglycerides is considered anything over 150 milligrams per deciliter. And this is especially if they're undergoing drug therapy for high triglycerides. Low HDL cholesterol is anything below 40 milligrams per deciliter in men and below 50 in women, or if they're undergoing therapy for reduced HDLs. Hyperglycemia is a fasting glucose over 100 milligrams per deciliter, or if they're already using some type of drug therapy for hyperglycemia or diabetes. High blood pressure is a systolic over 130 millimeters of mercury or higher, or a diastolic of 85 millimeters of mercury or higher, or if they're undergoing drug therapy for hypertension. And lastly, a waist circumference of 40 inches or more for men and 35 inches or more for women. And of course, this is going to depend on ethnicity, the country, or geographical region within the country. Treatment really has two primary goals here. We want to reduce the risk for atherosclerotic disease and reduce the risk for type 2 diabetes. In addition, specific treatment should be directed at lowering blood pressure and triglyceride levels as well. And we want our patients to take low-dose aspirin because this is going to reduce the risk of thrombus, unless they're already on a regimen of another type of anticoagulant for other medical reasons, or they have a high risk for intracranial bleeding or hemorrhagic stroke. Now, the term metabolic syndrome is widely used, but there's a debate about its clinical relevance. And in the cardiovascular community of providers, most clinicians believe that this term metabolic syndrome has a lot of utility in determining a patient's risk and overall health. But in the diabetes community, many clinicians feel that this term is actually misleading, and it implies that the existence of a specific disease entity, even though it's not defined and it's only a cluster of risk factors put together, may not have a common underlying cause. Clinicians that work with diabetic patients, they point out that the risks associated with the diagnosis of metabolic syndrome is no greater than the sum of the risks of all its components, meaning that they want more proof that metabolic syndrome actually exists and that the term doesn't really serve any clinical purpose. So for these practitioners, they think that we should not use that term metabolic syndrome at all. Now, even though we have two different schools of thought, the idea is that if we don't use the term metabolic syndrome, or we do use the term metabolic syndrome, this patient has a cluster of these metabolic disorders that put them at a high risk of cardiovascular disease. So think about this when you are trying to target cholesterol levels. We're going to look at drugs for angina pectoris. Now, angina or chest pain, mainly we're going to attribute this to a cardiovascular disease. It's a sudden pain that occurs beneath the sternum, and it usually radiates to the left arm and the left shoulder. Remembering that women present differently than men, not all angina will have this radiation. Anginal pain is precipitated when our oxygen supply to our own heart muscle tissue is insufficient to meet the demand that our heart requires, that oxygen demand. And most importantly, it occurs secondary to atherosclerosis of coronary arteries. So this angina that your patient is experiencing is a symptom of a disease, but it's not a disease of itself. And in the US, more than 10 million people have chronic stable angina. So our drug therapy for angina has two different goals. We want to prevent myocardial infarction or heart attacks and death. And secondly, we want to prevent myocardial ischemia and anginal pain. And the two types of drugs that we're going to use to decrease the risk for MI and death are those that lower cholesterol and antiplatelet drugs. However, first we're going to focus on the anti-anginal drugs. These are the ones that are going to prevent myocardial ischemia and the pain associated with angina. There are three main groups of anti-anginal drugs. These are the organic nitrates, so for instance, nitroglycerin, the beta blockers like metoprolol, and the calcium channel blockers like verapamil. Sometimes, in addition, there's a fourth agent, ranolazide. It can be combined with these drugs to supplement the effects. Most of what we're going to be talking about in the next few slides is going to focus on organic nitrates because we've already talked about beta blockers and calcium channel blockers previously. Let's take a more close overview of these therapeutic agents, remembering that stable angina can be treated with the three main drugs, the organic nitrates, the beta blockers, calcium channel blockers. But like I've said earlier, we can also use renoxaline in combination to help with additional benefits. Now, all four of these groups of medication are going to help relieve the pain of stable angina, and the primary mechanism is the decrease in cardiac oxygen demand. Now, these drugs can only help provide symptomatic relief. They're not going to affect or improve the underlying pathology causing this increased oxygen demand and pain. So, to reduce the risk of MI, all patients with known cardiovascular disease should receive an antiplatelet drug like aspirin, unless it's contraindicated. Again, somebody that has an increased risk for intracranial hemorrhage would not be a candidate for aspirin. Now, there are some non-drug therapies that we want to use in addition to support a stable angina. We want them to attempt to avoid the factors that precipitate angina, like overexertion, eating heavy meals, increasing exposure to cold, and even emotional stress. And these risk factors should be corrected if possible. However, sometimes they're very hard to treat. Now, things like smoking, hypertension, hyperlipidemia, having a sedentary lifestyle are always topics of healthcare that you would want to discuss with your patients. And it's strongly encouraged for them to quit smoking because of the pathophysiology of nicotine on our already atherosclerotic vessels. Now, patients with a sedentary lifestyle need to be encouraged to establish some type of regular program for aerobic exercise. And those that have hypertension and hyperlipidemia, hopefully these are already being addressed as well, and they need to be treated also. You can see that in general, when you use nitrates, they're working on decreasing the oxygen demand in terms of vein dilation, and this is going to help decrease the preload. With beta blockers, they're decreasing oxygen demand by decreasing your heart rate and your contractility. Calcium channel blockers will decrease oxygen demand, but they're working on the arterioles. They're going to help dilate and decrease afterload. They also will decrease your heart rate and contractility as well, but only verapamil and diltiazem. And then lastly, ranolazine. This appears to help decrease oxygen demand by helping the myocardium generate energy more efficiently. antiplatelet drugs decrease platelet aggregation, and when you are able to do this, it will decrease the risk for thrombus formation in the coronary arteries, hoping to decrease the risk for MI. And the most effective agents that we use are aspirin and clopidogrel, which is also called Plavix. In patients with stable angina, you can use a low-dose aspirin, usually 81 milligrams, and this is going to produce a 33% decrease in the risk for adverse cardiovascular events. There are some benefits of using clopidogrel as well, and it's similar to and equal to that of aspirin, although we don't have very much documentation yet. The guidelines recommend that all patients that have stable angina take at least 75 milligrams to 162 milligrams of aspirin every day, unless, again, there is a contraindication. Aspirin, clopidogrel, and all the other antiplatelet drugs that you can see here are effective for anticoagulant antiplatelet therapies. We can also use for anticoagulants sub-Q low-dose heparin, or low molecular weight heparin, like Lovenox. We can use direct thrombin inhibitors like Angiomax. We can also use something that will inhibit factor XA, like Arixtrol, or an IV unfractionated heparin. And all these drugs will help reduce the risk of that thrombus formation in our coronary arteries. So we've looked at medical treatments that can decrease the risk of MI and death in patients with chronic stable angina. And therapy is directed on prevention of MI and death, which is a shift in the paradigm of treatment. And now we're really looking at managing stable angina, and all nurse practitioners should become familiar with this prevention therapy goal. So again, with the use of antiplatelet drugs, cholesterol-lowering drugs, using ACE inhibitors, and anti-anginal agents together, we're hoping to bring down the risk of MI considerably. And you can see with this algorithm here some ways of doing this. And giving a sublingual nitrogen and then adding a beta blocker, especially if someone has already had a previous MI. If that treatment is not successful or there's contraindications, we can substitute that with using a calcium channel blocker. Now, if this isn't working, then we can add a nitrate, but now we're using a long-acting nitrate. And if that's not working, then medication is not going to be the answer. We're going to have to consider revascularization by doing a bypass or using PCI. This section is on anticoagulant, antiplatelet, and thrombolytic drugs. Hemostasis is a physiologic process that stops bleeding, and it occurs in two different stages. We have the formation of the platelet plug, and then, of course, because it's unstable, this platelet plug has to be reinforced with fibrin. So first, let's start with stage 1, which is the formation of the platelet plug. Platelet aggregation is initiated when the platelets come in contact with collagen, and this happens at the damaged blood vessel when it's exposed to the surface. And in response to the contact with collagen, the platelets are going to adhere to that site of blood vessel. This is called adhesion. Platelet adhesion initiates platelet activation, which then turns and leads to massive platelet aggregation. And platelet aggregation is a complex process. It has to do with the formation of fibrinogen, which bridges between glycoprotein receptors and the adjacent platelets. Now, these aggregated platelets constitute a plug, and this plug is going to be what stops the bleeding.
But because it's unstable, we have to reinforce it with fibrin. Well, stage 2 is coagulation. And by definition, coagulation is the production of this fibrin. Fibrin's made out of thread-like proteins that reinforce that platelet plug. Fibrin's produced by two convergent pathways. We have the intrinsic pathway, or the contact activation pathway, and we also have the extrinsic pathway, or the tissue factor pathway. When these two pathways converge at factor XA, this is going to set off a continuing cascade to eventually form the fibrin that is needed. We also need to keep hemostasis under control, and this is going to protect against widespread coagulation, and our body has to be able to inactivate clotting factors if they move away from where they need to be at the vessel injury. And this is accomplished by antithrombin. Antithrombin is a protein that forms a complex, and this complex has clotting factors and inhibits their activity. The clotting factors that can be neutralized by antithrombin, you can see in this illustration, and intimately, antithrombin is involved in the action of heparin, which we're going to talk about in the next slide, and heparin is an injectable anticoagulant drug. There's also the physiologic removal of clots, and as our body is able to heal this injured vessel, the removal of the clot has to occur, and eventually it's necessary. How does the body do this? Through plasmin. Now, plasmin is an enzyme that degrades the fibrin meshwork of that clot, and it's produced through the activation of its precursor. Plasminogen will activate plasmin. The fibrinolytic drugs like alteplase will act by promoting the conversion of plasminogen to plasmin. We also need to talk about thrombosis. We either have arterial or venous thrombosis. A thrombus is a blood clot formed in the blood vessel or in the heart. Thrombosis formation reflects a pathologic functioning of hemostatic mechanisms. In the arterial system, the formation of an arterial thrombus begins with adhesion of platelets to the arterial wall. Adhesion is stimulated by the damage to that wall, remembering that atherosclerotic plaques can rupture, activating platelet adhesion. In the venous system, venous thrombi develop at the sites where blood flow is really slow, and you have that stagnation of blood, remembering that the venous system is a lower pressure system. This stagnation initiates the coagulation cascade, and it results in the production of fibrin. This fibrin is going to enmesh the red blood cells and platelets to form a thrombus. And typically these venous thrombi, they have long tails that can break off and produce an embolus. And as the emboli travels through our vascular system, it can be lodged in different areas, frequently in our pulmonary arteries, and this is what causes a pulmonary embolism. Unlike arterial thrombi, the harmful effects are localized with venous thrombosis. The injury from a venous thrombus occurs secondary to embolization at the site that's distant from the original thrombus. The difference is in the arterial thrombus, the consequence is localized tissue injury and lack of perfusion. There are three major groups of drugs that we use for thromboembolic disorders. Anticoagulants, which disrupt the coagulation cascade, and they're going to suppress the production of fibrin. We have antiplatelets that are going to inhibit platelet aggregation, and then we also have thrombolytics, and this is going to promote the lysis of fibrin, which will overall cause the dissolution of the thrombi. And although the anticoagulants and antiplatelets drugs will both suppress thrombosis, they do it through these different mechanisms. And as a result, their effects and their applications are also different. The antiplatelet drugs are most effective at preventing arterial thrombosis, where anticoagulants are more effective at treating against venous thrombosis. And you can see the overview of these drugs on this list with their trade name and the routes that they are available in. Make sure that you review the mechanism of action and understand the therapeutic use for each of these classes. Low molecular weight heparins are great for our patients because we don't have to monitor their APTT like we would with unfractionated heparin. Because low molecular weight heparins are heparins that are prepared composed of molecules that are shorter, we can effectively use them at home without monitoring. Because of this advantage, they are considered the first-line treatment for the prevention and treatment of DVT, but you can also see here that there are some other therapeutic uses. It's safe to be used during pregnancy, it's safe to be used during cardiac surgery, renal dialysis, post-op prevention, DIC, and it can be used as an adjunct for a myocardial infarction. However, the main adverse effect that we are trying to avoid is hemorrhage and, of course, heparin-induced thrombocytopenia. When you are administering a low molecular weight heparin, you want to think about the signs and symptoms that may tell you that your patient is undergoing signs of blood loss. Think about decrease in blood pressure, increased heart rate, bruising, petechiae, hematomas, the quality of the stool and urine, so discoloration, red or black stools, cloudy discolored urine. Sometimes our patients will complain about pelvic pain that will suggest ovarian hemorrhage. Sometimes they complain about headache or faintness, which will suggest cerebral hemorrhaging. And sometimes they will complain about lumbar pain, and this tells us that maybe the adrenal glands are hemorrhaging. And of course, if there's any bleeding that develops, we have to stop the heparin as soon as possible. Now, we can also reduce the risk of hemorrhaging. First, you have to think about the dosage, being very careful that we are going low and slow, and that the activated partial thromblastin time, or the APTT, doesn't exceed twice the control value. And additionally, our patients that are candidates for heparin therapy, they have to be screened for other risk factors. And we shouldn't be using them with drugs like aspirin or clopidogrel because they're antiplatelet drugs. They need to be avoided. With heparin-induced thrombocytopenia, remembering that this is an immune-mediated disorder and it's characterized primarily by the reduction of platelet counts in the blood, we need to monitor for signs that the platelets are actually decreased. And sometimes we'll see in our patients petechiae, and we'll see purpura as signs, but overall we have to get their labs and make sure that they are not under 100,000. If they are under 100,000, heparin should be discontinued at this time. If they do need heparin, and the primary treatment for heparin-induced thrombocytopenia is going to be the discontinuation of heparin, then you have to use a different anticoagulation method. And you can use a non-heparin anticoagulant like argatroban. And really, the incidence of heparin-induced thrombocytopenia is only up to about 5% of the patients that do receive heparin for more than 4 days. There are some warnings and contradictions with the use of low molecular weight heparins. They need to be used with extreme caution in patients that have a high likelihood of bleeding. So think about patients that have absent clotting factors or hemophilia, if they have increased capillary permeability, dissecting aneurysm, if they suffer from peptic ulcer disease, already have severe hypertension, or they are undergoing a threatened abortion or miscarriage. Heparin also has to be used consciously in our patients that have underlying liver or kidney disease.
It's contraindicated with patients that already have thrombocytopenia and uncontrollable bleeding. And additionally, it needs to be avoided during specific surgeries. Now, although cardiac surgery is okay, you never want to continue heparin if there is a patient that is having surgery of the eye, the brain, or the spinal cord. Anyone that needs a lumbar puncture or using regional anesthesia, we also have to consider this as additional contraindications for the drug. If heparin treated patients are using this low molecular weight type heparin, platelet aggregation is the major remaining defense against our body's hemorrhaging, and aspirin and other drugs that also depress platelet function or affect our coagulation will weaken this defense and then employ a greater risk. So we have to use it with caution. We also have to keep in mind that ongoing laboratory monitoring will be something that we have to consider, and remembering that the objective of anticoagulant therapy is to reduce blood coagulability, but just to a level that's low enough to prevent thrombosis, but not low enough to promote any type of spontaneous bleeding. The tests that are most oftenly ordered are going to be your APTT or your anti-XA factor level. Remembering that APTT stands for activated partial thromboblastin time. So what exactly is that mechanism of action for low molecular weight heparin? Well, the anticoagulant activity is mediated by the same active penta, meaning 5 saccharide sequence that mediates the anticoagulant action of unfractionated heparin. But because the low molecular weight heparin molecules are shorter, they don't have the same effect. Specifically, where unfractionated heparin is equally good at inactivating factor XA and thrombin, our low molecular weight heparins preferentially will inactivate factor XA, being much less likely to inactivate thrombin. So it's very much more specific. To inactivate thrombin, a heparin chain has to not only contain the pentasaccharide sequence that activates our antithrombin, but it also has to be long enough to provide the binding site for thrombin. And this is why the low molecular weight heparins are better, because they are short and they're not going to bind to that site for thrombin. So the binding site is necessary because the inactivation of thrombin requires the simultaneous binding of thrombin with heparin and antithrombin. So unfractionated heparin chains, most but not all of them, the low molecular weight heparin chains are too short to allow thrombin binding, and this is why we prefer the low molecular weight heparins. They're going to be less likely and less able to activate thrombin. Again, this is why we don't have to follow up so often with their APTT and give the unfractionated heparin that requires in-hospital IV use. On this slide, you can compare the different types of unfractionated heparins, or the low molecular weight heparins, and you can look and see how they are metabolized, mostly in the hepatic metabolism and excreted by the renal system. You can also see how they are available. Heparin is available in IV and sub-Q, and the different units that are prescribed for the different indications are also on here as well. Now, there are some patient-centered care concerns that you want to think about when prescribing an anticoagulant. For infants, heparin is commonly used if an infant needs an anticoagulant, although argatroban has been used successfully in infants with heparin-induced thrombocytopenia. So that can be a second line if your patient has HIT. You can also use warfarin in infants as well, and we'll talk about warfarin on the next slide.
For children and adolescents, there are many anticoagulants that can be used safely. We just need to use them in smaller doses and think about the side effects, but they're very similar to those of adults. Now, warfarin is contraindicated in pregnancy, and this is why low molecular weight heparins and unfractionated heparins can be used during pregnancy. And in pregnant women that have HIT or HIT, you can also use argatroban, which is a safer alternative. With breastfeeding women, we don't have enough information yet, but so far we know that warfarin and heparin are generally both safe to use, but it would be helpful to have more data to support this. And lastly, with our older adults, embolic stroke from AFib is the most common concern, and usually anticoagulation is recommended to reduce the risk. However, therapy should be individualized based on that individual's risk for bleeding. When you are prescribing for our patients and you need to consider an anticoagulant therapy, think about what that overall therapeutic goal is. Get your baseline labs or baseline data, continue to monitor, understand and identify who the high-risk patients are, evaluate if it's actually working and where those therapeutic levels are, and how you're going to minimize adverse effects. And partially, you will need to do a lot of patient education. Now, warfarin, commonly known as Coumadin, is different than a low molecular weight heparin. It's a vitamin K antagonist, and it is the oldest oral anticoagulant available. And it's similar to heparin in the respect that it's going to help and serve as an anticoagulant, but it's different than heparin. So it's used to prevent thrombosis, but in contrast to what heparin does, warfarin has a delayed onset. So it makes it not appropriate for emergency situations. But because we don't have to inject the medication, we can actually use this for long-term prophylaxis a little bit more successfully. Warfarin carries a significant risk for hemorrhage also, and it's amplified by any other drug interaction that will also have that same mechanism of action of being an anticoagulant or an antiplatelet. The mechanism of action of warfarin is a suppression of coagulation by decreasing the production of the 4 clotting factors. And these factors are known as the vitamin K dependent clotting factors, because in the active form of vitamin K is needed to make these clotting factors happen. Warfarin is going to work by inhibiting vitamin K, the epoxide reductase complex. We also call that the VKORC1, and this is an enzyme that's needed to convert vitamin K to an active form. So without the VKORC1, our vitamin K would not be active. Because of the mechanism of action of warfarin, we call this a vitamin K antagonist. It's kind of misleading though, because it implies antagonism of vitamin K actions, but really it's the antagonist of the making and activation of these 4 clotting factors. The 4 clotting factors are 7, 9, and 10, and prothrombin. There are several therapeutic uses for warfarin, and we can frequently use it as a long-term prophylaxis in thrombosis. And again, remembering because of the ability to use it in oral form. The indications, some of them are trying to prevent venous thrombosis or an associated pulmonary embolism from a venous thrombosis. We're also trying to prevent thromboembolism in patients that have a prosthetic heart valve, and the prevention of thrombosis in our AFib patients.
Warfarin has been used to reduce the risk of recurrent transient ischemic attacks and recurrent MI. So it is a great prophylaxis overall. Because the onset of the effects is delayed, we don't want to use it in an emergent situation. If we need something to act more rapidly, then anticoagulant therapy has to be initiated with something that's going to be more fast acting. We can start with warfarin, but really you need to get heparin on board. Now, the objective of treatment is to raise the international normalized ratio, or the INR, and we're trying to get that to an appropriate level. The recommended INR ranges can be found in the book, but as indicated, INR of 2 to 3 is appropriate for most patients. Although some patients, you need a little bit higher INR of 2.5 and 3.5. Because warfarin has this delayed onset and prolonged duration of action, the INR can't be altered quickly. So after the dosage has changed, you may have to take a week or two before you can recheck to see if you have met the desired INR. And just like heparin, warfarin has adverse effects, the main one being hemorrhaging. Bleeding is that major complication. You have to monitor your patient closely for signs of bleeding, just like you would with heparin. Now, if bleeding develops, you have to discontinue warfarin as well. And for severe overdoses, you want to treat with vitamin K to counteract warfarin. Understanding that mechanism of action will help you understand why vitamin K would be the antidote for severe overdose. Patients that are on warfarin are really encouraged to carry some type of identification that allows emergency personnel to know that they are on warfarin, and this will help them to not be over-medicated with other anticoagulants or antiplatelets in an emergent situation. Now, there are several measures that can reduce the risk for bleeding for patients that are on warfarin therapy. We have to think about who these patients are, carefully monitor them to make sure that they don't meet any of the criteria for contraindication. And of course, we're measuring their international normalized ratio, or the INR, frequently. You also want to think about talking to your patients in detail. Both verbal and written instructions have to be given to help them understand the signs of bleeding, the dosage size, and the timing, and also when their INR tests need to be scheduled. Patients shouldn't be using a hard or medium toothbrush. You always want to use a soft toothbrush because you don't want to invoke gingival bleeding, and also you want to promote the use of an electric razor to reduce cuts from shaving. Now, during surgery, warfarin will intensify the bleeding, and so surgeons have to know if your patient is on warfarin, and those that are anticipating any type of elective procedures, your primary care provider, so for you as an NP, you have to discontinue the warfarin at least 5 days before the appointment. If an emergent procedure has to be performed, then they're going to provide vitamin K to the patient to help suppress the bleeding that will come about from warfarin use. For pregnancy, for women that are pregnant, fetal hemorrhage and teratogenesis can occur. Teratogenesis is anything that will cause gross malformations of the fetus, and this can happen in the central nervous system. It can cause optic atrophy. It crosses the placenta and it will affect the developing fetus. In fatal occasions, fetal hemorrhage will occur, and this will lead to death. If pregnancy occurs because the woman doesn't know that she is pregnant, there is the possibility of termination that most providers will discuss with their patients, but if there is an anticoagulant that is needed, you really need to promote the use of low molecular weight heparin. Again, this is not going to cross the placenta, but warfarin will cross the placenta. It also enters breast milk, and we should not advise our patients to breastfeed while on warfarin. So again, you can use low molecular weight heparin for those things. There are interactions between warfarin and the other drugs. Any drug that fits in these categories should not be used. Drugs that increase anticoagulant effects, drugs that promote bleeding, or drugs that decrease anticoagulant effects. The major mechanisms by which anticoagulant effects increase are the displacement of warfarin from plasma albumin, the inhibition of hepatic enzymes that will degrade warfarin, decreased synthesis of clotting factors. The major mechanisms for decreasing anticoagulant effects is the acceleration of warfarin degradation through induction of hepatic drug metabolizing enzymes, the increased synthesis of clotting factors, inhibition of warfarin absorption, and the mechanisms by which drugs can promote bleeding and thereby complicate anticoagulation therapies are the inhibition of platelet aggregation, inhibition of clotting factors, and generation of GI type ulcers. Now, like heparin, warfarin is contraindicated for patients with severe thrombocytopenia, uncontrollable bleeding, if they've had a underlying disease and they're missing clotting factors, if they are going to have a lumbar puncture, regional anesthesia, or any surgery of the eye, brain, and spinal cord. As a rule, small doses are preferred, 2.5 milligrams PO. The large doses can go up to about 10 milligrams PO, but remember, you do want to start low. Using large doses can cause prolonged resistance to warfarin, and so therefore, when you do need warfarin, it's going to hamper that anticoagulation effect. What happens if vitamin K doesn't control bleeding, or if there is an organ that's being threatened by bleeding? The levels of clotting factors can be raised quickly by infusing fresh whole blood or fresh frozen plasma or plasma concentrates that have vitamin K dependent clotting factors in them. So that would be a second line way to correct an overdose of warfarin. Now think about vitamin K in your diet. The dietary vitamin K reduces anticoagulant effects of warfarin, and so many times you are going to teach your patient, if you're on warfarin, you don't want to eat things that are high in vitamin K, and these things include mayonnaise, canola oil, soybean oil, green leafy vegetables. Definitely spinach is not good to take when you are on warfarin. They don't have to avoid these foods completely, but just monitor their intake so that their intake of vitamin K is just constant. It's not going up too high or down too low, because it will change the therapeutic effect of warfarin in their body. So when vitamin K increases in your diet, warfarin is going to increase as well. And if vitamin K intake decreases, warfarin dosage should also be decreased. There are some contrasts between warfarin and heparin. Although heparin and warfarin are both anticoagulants, warfarin is given orally, heparin is given by injection, and this can sometimes also inform which drug you can use. Now, both drugs are going to decrease fibrin formation, but they're doing it with different mechanisms, and I want you to understand the two different mechanisms in which this is achieved. Heparin will inactivate thrombin and factor XA, and warfarin is inhibiting the synthesis of clotting factors. Heparin and warfarin will differ also in the time and course of action. The effects of heparin begin and fade rapidly, and the effects of warfarin begin slowly, and they're going to persist for several days. And then lastly, you need to think about what tests are going to help inform your monitoring. Changes in APTT, we use that for heparin treatment, and changes in PT will help us to monitor warfarin. And then finally, you have to think about the management of overdose. Protamine is given to counteract heparin, and vitamin K is given to counteract warfarin. And here to summarize a little bit more thoroughly the key points for warfarin, we know that our therapeutic goal is to prevent thrombus. We need baseline data like PT, CBC. You might want to see if there are absences of the CYP269 enzyme or VKORC, and we need to identify those patients because it's going to require that as a provider we reduce the dosage that we're prescribing of warfarin. We use PT and INR to monitor them and to make sure that they are on a safe dose, and we're doing it frequently at the onset of therapy. For the first initial few days we're doing it daily, and then we go to every few days, and once we get an INR goal that is expected or what we are desiring, we'll go to a weekly basis, and then we can also move into a monthly basis as well. Identify those patients that are high risk. Remember that pregnancy is a contraindication. Those that are breastfeeding, the warfarin will cross the placenta. We have to use it in caution with patients that have a vitamin K deficiency, liver disease, or anyone that's already at a very high risk for bleeding. Our last section for this week is drugs for deficiency anemias, and we're going to start first with understanding what anemia is. It is the reduction or the decrease in erythrocytes, and this could be in number, size, or the hemoglobin content in the RBCs, and it's caused by either blood loss, hemolysis, or there's a deficiency of the substances that are essential for RBC formation and maturation in our bone marrow, causing a dysfunction. Important to know that the daily requirement of iron in our body is really determined largely by the rate of the erythrocyte production. And when our RBC production is low, our iron needs are low too. When RBC production is high, our iron will also rise. This is going to be important because we're going to first talk about iron deficiency anemia. For iron deficiency anemia, the treatment first line is going to be using a ferrous sulfate. And some adverse effects that we need to think about are GI disturbances. Those are what our patients are going to complain about most. So think about nausea, heartburn, bloating, constipation, and diarrhea. Additionally, there's other GI effects. Oral iron can actually cause dark green or black color to your stools. It can stain your teeth as well. Iron can cause toxicity if it's given in large amounts, so you want to make sure that you're dosing correctly. It's almost always the result of accidental or unintentional overdose, not from using a therapeutic dose. Death from iron ingestion is very rare in adults, but in young children, iron-containing products remain among the leading cause of poisoning fatalities. So make sure you are prescribing very carefully doses of iron for our pediatric patients. A lethal dose of elemental iron is about 2 to 10 grams of iron. So to reduce this risk, obviously dose correctly, but use childproof containers to make sure that they are not just taking all their iron pills at once. We do have to think about drug interactions with iron and any drug that can alter the absorption of iron or both. Antacids reduce the absorption of iron. So when you give antacids with iron, with tetracyclines. This will also decrease absorption of both the tetracycline antibiotic and iron. Absorbic acid or vitamin C promotes iron absorption, and this is why we like to tell our patients to take their iron with a glass of orange juice. It's also going to increase the adverse effects as well. Attempts to enhance iron uptake by combining iron with absorbic acid doesn't really offer an advantage over just simply taking a larger iron dose. I do want to go back and just review that while ferrous sulfate is usually the treatment of choice, there are two basic types of iron salts. There's the ferrous salts and the ferric salts, and we are going to be talking more about the ferrous iron salts. There are 4 different types available. They're ferrous sulfate, ferrous gluconate, ferrous fumarate, and ferrous aspartate. But again, it's the ferrous sulfate that is most prescribed. So before you treat for iron deficiency, you want to understand what that etiology of the iron deficiency is. Potentially, it could be pregnancy, bleeding, inadequate diet. It's rarely because of a lack of intestinal absorption of iron. Our main objective is to increase the production of hemoglobin and erythrocytes. And so when therapy is successful, our reticulocytes are going to increase, and we usually see this within a week. We are hoping for increases in hemoglobin and hematocrit. So we use this as a lab marker to help us to understand if our therapy is improving our patients. And usually within a month, we're going to see elevated levels of hemoglobin and hematocrit. Our hemoglobin specifically should rise at least 2 grams per deciliter within 4 weeks. Now, if this doesn't help, the patient needs to be evaluated and re-evaluated for compliance, but also if there's a site of bleeding or if they have inflammatory disease that can interfere with hemoglobin production. And lastly, we would look for malabsorption of oral iron, but again, that's the least likely. Oral iron is preferred because it's safer than parenteral iron, but it's just as effective. Parenteral iron should be used only if oral iron is ineffective or the patient can't tolerate oral doses of iron. Now, if you do give a parenteral route, the IV route is safer and preferred. When we use oral iron, we should continue to monitor hemoglobin levels until they become normal. So we're shooting for around 15, but it's different in male and females. The phase of treatment is going to be about 1 to 2 months, and then we will reevaluate. And sometimes continued treatment can help replenish the ferritin stores, but for some patients, dietary iron alone after you've gotten them up to a normal level is going to be sufficient. Now, as a rule, combining anti-anemic agents should be avoided. So you wouldn't give them an oral iron plus a parenteral iron because it can lead to iron toxicity. You should also think about the use of oral iron not being used when you're giving iron injections as well. So always just pick one route and don't combine it with anything else. The combination of iron with vitamin B12 and folic acid, we should also avoid that as well, and we're gonna see why in the upcoming slides. We're going to talk about vitamin B12 deficiency, which is also a type of anemia. Sometimes you've heard it as pernicious anemia, and that term pernicious, we don't actually, when we shouldn't really be calling it pernicious anemia anymore. Before, we had an ability to treat vitamin B12 deficiency. Many times our patients would actually die because of vitamin B12 deficiency. But now, because we are able to correct the vitamin B12 deficiency, we typically don't use that term any longer. We do treat our vitamin B12 deficient patients depending on if it's moderate or severe. And actually, even if you are unable to absorb B12, which is a primary reason of having B12 deficiency, that lack of intrinsic factor that's needed, remembering that that's secreted by the parietal cells in our stomach. Well, if we don't have intrinsic factor, we are still able to get some passive absorption of vitamin B12 through passive diffusion. And so you don't need intrinsic factor for that. But it's a very small percent, only about 1%. Vitamin B12 is excreted very slowly, and because of that, only 0.1% of the body stores of vitamin B12 are lost. So this slow excretion points to vitamin B12 deficiency developing very slowly over years. It's not something that happens quickly. In most cases, vitamin B12 deficiency is the result of impaired absorption. It's only rarely because there's insufficient B12 in the diet. However, our patients that are vegan have a higher risk for vitamin B12 deficiency. Those patients that have undergone bariatric surgery or have GI diseases like celiac disease, they will also be at higher risk because they're not absorbing the B12 properly. Now, when B12 deficiency is caused by the absence of intrinsic factor, that's when it used to be called pernicious anemia. But now we can manage it more successfully. And to manage it, we have to think about the hematological effects of vitamin B12 deficiency. It can be reversed with large doses of folic acid. But when folic acid is present in large amounts, some of it can be activated by an alternative pathway that's independent of vitamin B12. And this pathway will bypass a metabolic block that causes B12 deficiency, and it's going to permit DNA synthesis to further proceed. The reason why vitamin B12 can be so severe is that it causes neurologic damage, which we don't see in iron deficiency anemias. This vitamin B12 deficiency can cause demyelination of the neurons. Primarily, it's going to happen in the spinal cord and the brain. And so you're going to see a lot of neurologic type symptoms, loss of memory, mood changes, hallucinations, and psychosis. And if this B12 deficiency is prolonged, neurologic damage can actually become more permanent. How do we diagnose this megaloblastic type anemia? Due to vitamin B12 deficiency or other causes, especially the lack of folic acid, therapy is appropriate. And we need that definite diagnosis that we can do by just getting a CBC and measuring for B12 and folic acid deficiency. The combination of a megaloblastic anemia plus a vitamin B12 anemia can both be treated. Now, for moderate B12 deficiency, the primary manifestation that you're going to see are these megaloblasts in the bone marrow, and we're going to see macrocytes in the peripheral blood. Moderate deficiency doesn't cause leukopenia, doesn't cause thrombocytopenia, or any major neurologic complications. And so we can manage this by just supplementing B12 alone. But for those patients that have severe B12 deficiency, we're going to see that it's going to produce multiple effects, and we have to treat all the different effects. So unlike mild B12 deficiency, erythrocytes are the only blood cells that are affected in mild deficiency. However, with severe deficiency, it's also going to disrupt the production of our erythrocytes and all the blood cells. The loss of erythrocytes will lead to further hypoxia, cerebrovascular insufficiency, and even can cause heart failure. The loss of leukocytes will encourage infection, and the loss of thrombocytes obviously will promote bleeding. Additionally, we will also see adverse effects to our GI tract, and we've already talked about the adverse effects on the nervous system. When we treat for severe B12 deficiency, we have to provide IM injections of B12 and folic acid
because that folic acid is going to accelerate the recovery of the hematological defects that the severe vitamin B12 deficiency has caused. We need to administer 2 to 3 units of packed RBCs as well, because we're trying to correct the anemia very quickly. We need to transfuse platelets and think about therapies with antibiotics as well because of the loss of leukocytes that occurs. Remembering that it's not just going to be the erythrocytes that are low, it's going to be all our blood cells in danger. Now, after we treat with vitamin B12 plus folic acid, we will actually see recovery from this type of anemia happening very quickly. Usually within 1 to 2 days, the megaloblasts are going to disappear from the bone marrow, and within 3 to 5 days, our retic count, or the reticulocytes, are going to become more elevated. By the 10th day, this is when we would expect to see our hematocrit rise, and within 2 weeks to 3 weeks, the hematocrit is going to be back at a normal level. So we're going to see a improvement in our overall blood components, but recovery from neurologic damage is going to be slower, and it's going to depend on how much damage was present in the first place. Sometimes these neurologic deficits can take about 2 to 3 months for them to recover, but even then, this is still relatively fast compared to if you don't provide treatment of vitamin B12 deficiency at all. Now, if you've seen a vitamin B12 deficiency or have experienced symptoms for months upon months or even for years, the recovery is obviously going to be slower. So don't give your patient false hope that it's all going to be better all at once. And for some patients, because it was so severe, the neurological damage can actually be long withstanding and cannot be reversed. So think about long-term treatment, and those are going to be for patients that don't have intrinsic factor, or they have some other permanent cause where vitamin B12 is not going to be absorbed. These patients are not just going to have their 2 to 3 months of B12 injections. They're going to have lifelong treatment. And this is going to be required in either a monthly IM or a sub-Q injection. And we're giving cyanocobalamine. However, these large daily oral doses can also be effective as weekly intranasal doses as well. For prolonged therapy, the treatment has to be reassessed periodically, and we're looking for the plasma levels of B12. We want to measure them every 3 to 6 months, but we're also looking at their CBC as well. We're trying to monitor the return of macrocytes, and therefore we're getting a complete blood count. There is a potential hazard of using folic acid, that treatment with folic acid can actually exacerbate neurological consequences that we will see in our B12 deficiency. Think about folic acid for a second. By itself, it can reverse the hematological effects of B12 deficiency, but it's not going to alleviate the neurological deficits. So if we correct the most obvious manifestations of B12 deficiency anemia, folic acid can mask the fact that the deficiency of B12 is still existing. So the use of folic acid can lead to undertreatment of B12 and thereby permitting neurological damage to actually progress because it's masking the effects. So folic acid isn't a substitute for B12. Vitamin B12 deficiency should never be treated with just folic acid. You have to use B12 to replace the B12 deficiency. It's important to know the difference between folic acid deficiency and vitamin B12 deficiency. However, there is a commonality. In both of these deficiencies, we're going to have a megaloblastic anemia. And this is the most common conspicuous pathology. But in the presence of megaloblastic anemia, it's still really important to determine if the etiology is deficiency of folic acid or deficiency of vitamin B12, and sometimes it can even be both, and this is going to inform your treatment. Just like vitamin B12, folic acid is necessary because it is a factor for DNA synthesis, and without folic acid, DNA replication and cell division can't proceed. To be usable, dietary folic acid has to be first converted to an active form. And in a healthy patient, activation occurs through a pathway that employs vitamin B12 as well. However, when large amounts of folate are being ingested, some can be activated through an alternative pathway, and we don't need vitamin B12. So therefore, in the absence of vitamin B12, if we do have sufficient amounts of folic acid being consumed in our diet, active folate is available for DNA synthesis. It's absorbed in the early segments of our small intestines and transported by the liver. And then it's used in our other tissues, and it's stored primarily in the liver. It also undergoes this extensive enterohepatic recirculation. And what that means is that even though folate from the liver is excreted into the intestines, it's going to be reabsorbed and then returned back to the liver. And this is through the hepatic portal circulation. This recirculation is going to help us to keep and resavage 200 micrograms of folic acid a day. And because of this, we're able to maintain folate stores appropriately. But remember, with vitamin B12, we lose vitamin B12 very slowly. With folic acid, if we're not increasing or consuming folic acid, we're going to have a big drop in folic acid that occurs very rapidly, like within weeks. What are the causes of folic acid? It's principally either poor diet, and usually this is because a patient is abusing alcohol. And then secondly, it's going to be the malabsorption. That's because of intestinal diseases. With our patients with alcohol use disorder or abuse of alcohol, we are going to see folate deficiency because they're not eating enough folic acid, and drinking alcohol actually deranges the enterohepatic recirculation. And this is secondary again to alcohol-induced injury to the liver. However, it's fortunate that in alcohol use disorder, if we just improve the diet and we reduce alcohol consumption, we can actually reverse the effect of folate deficiency. SPRU is an intestinal malabsorption syndrome that decreases folic acid uptake. And because SPRU does not block folic acid absorption entirely, this deficiency can be corrected if we give large amounts of folic acid orally. There is a consequence of folic acid deficiency that is very similar to vitamin B12, except that it's not going to have the same effect on the nervous system. That's only B12 deficiency. But with folic acid deficiency, we are going to see the same consequences of megaloblastic anemia. We're going to see, because of the lack of folic acid, leukopenia, thrombocytopenia. We're going to see injury to the GI and oral mucosa. And just like we talked about before, if we don't have folic acid, it will suppress DNA synthesis. Folic acid is really important in consideration to the developing fetus. We know that deficiency occurs very early in pregnancy. With folic acid, you're going to result in a neural tube defect. So think of spina bifida and also anencephaly as well. So because of this, the U.S. Preventative Service Task Force, or the USPSTF, has recommended that all women that become pregnant need to consume 400 to 800 micrograms of supplemental folic acid in addition to what they are getting in their food. And this is why it has been added to prenatal vitamins. So what's the guideline for treating folic acid? Well, the modality of choice is a PO dose of folic acid. In the deficiency, if it's due to poor diet, of course we're going to correct the dietary folic acid, but even if you are taking enough through dietary measures, if you're pregnant, you're still going to get supplementation. Ingestion of a serving of fresh vegetables or a glass of fruit juice a day usually suffices. But again, if it's a folic
acid deficiency because of malabsorption, then we will always need to use supplemental folate. It's not going to be enough to just eat more foods with folic acid. We do prefer the oral administration over the injection, and it is known that oral folic acid is just as effective if we give the correct dose. In terms of prophylactic use of folic acid, we consider this for patients that could become pregnant, are pregnant, or breastfeeding. Because folic acid masks vitamin B12 deficiency, you have to think about using folic acid in situations where you need to monitor B12 deficiency as well. For severe folic acid deficiency, and remember it can produce severe megaloblastic anemia, we have to make sure that we are rapidly responding to this known folic acid deficiency. And so if it's severe enough, we can also inject with IM folic acid and vitamin B12. And the reason we're giving both is because there's a metabolic interrelationship between folic acid and vitamin B12. This combination is going to accelerate the recovery of severe severe folic acid deficiency. So we're going to use both. Now, after the initial injection, we are still going to monitor for folic acid, but just folic acid alone. And we're going to give oral PO doses of 1,000 to 2,000 micrograms a day for 1 to 2 weeks. And then the maintenance dose of folic acid will be 400 micrograms a day. And this is usually what's required. We will inform our therapy by getting a full hematologic picture, which is going to help us determine the therapy's course. And when treatment has been effective, the megaloblasts will actually disappear from the bone marrow. And this usually happens within 2 days. The retic count, or the reticulocyte count, this is also going to increase. And we're going to see this 2 to 3 days. And the hematocrit will also increase as well. And it takes about 2 weeks to see a difference there.